So this is the first video of hematology. First topic is transfusion reaction overview. So this bacterial contamination it's very rare with red cell transfusion like PRBC and more common with platelet transfusion which is stored at room temperature. So more chance of bacterial contamination. IgG antibodies causes delayed extravascular hemolytic transfusion reaction much more commonly than acute vascular. So IgG is delayed. IgM anti-A, anti-B antibodies cause acute hemolytic transfusion reaction. As little as 4 mm of transfused ABO incompatible blood can be fatal. ABO antigens are present from birth, whereas ABO antibodies are acquired in the first 6 months of life. Anti-O antibodies do not exist, and about 1 in 10,000 people are deficient in IgA and can form clinically significant complement binding antibodies to IgA. In many cases of apparent anaphylaxis to blood transfusion, the causative agent is unknown, but is putatively thought to be due to allergens in the donation, such as penicillin or peanut allergy. So this is just an overview of the things that you need to know, some common points. Delayed transfusion reaction occurs 3 to 15 days post-transfusion due to the development of red cell alloantibodies. Clinical features can be usually minimal, include unexplained fever, jaundice, or unexplained decreased hemoglobin. Diagnosis: urinalysis shows urobilinogenuria and blood film shows fragile balloon spirocytes. Diagnosis is confirmed by Coombs test, which is done by adding anti-human globulin, anti-IgG, and anti-complement to wash red blood cell. A positive test results in red cell agglutination. Okay, FFP can be stored for up to 24 months at minus 30 degrees centigrade. Red cells can store up to 4 degrees for up to 35 days. Platelets at 22 degrees for 5 days on a platelet shaker agitator. Moving to the next topic, important one: graft versus host disease. So acutely graft versus host disease is commonly associated with stem cell transplants, such as those that occur with bone marrow transplant in the first 100 days post-transplant, with chronic GVHD occurring 100 to 300 days post-transplant. So the presentation can be: GVHD is graded according to the Seattle system. Each organ involved in is scored. The skin, liver, gut. Rash is initially maculopapular, affecting palms and soles. So affect palm and soles first, may change to general erythroderma affecting the trunk and limb. And abdominal pain can also occur, right upper quadrant pain, diarrhea, bilirubin. And the management can be acute one, high dose methylprednisolone. Action is needed quickly. If there is no response, then more intensive immunosuppression is needed, such as alemtuzumab. If this is not working, then alemtuzumab or anti-lymphocyte and globulin. Chronic will be oral prednisolone. Okay, transfusion-associated GVHD includes non-irradiated whole blood, packed red blood cell, platelets, granulocyte, and fresh non-frozen plasma. And do not cause this is all this crap precipitated FFP and frozen deglycyrrolized red blood cell. Moving on to the blood films. Important features of the blood films that we need to know. Hyposplenism, you see like either postsplenectomy or maybe celiac disease. There will be target cell, Golgi bodies, carboat rings, steatotic granules, acanthocytes, schizocytes. In iron deficiency anemia, you will see target cells, pencil poikilocyte. Combined with B12 folate deficiency, dimorphic film occurs with mixed microcytic and macrocytic cells. Clinical finding of IDA: Koilonychia, atrophic glossitis, post-cricoid webs, angular stomatitis. Okay, these are very important, like the specific things that you would see in specific disease, like G6PD deficiency, you will see Heinz bodies, myelofibrosis, teardrop poikilocytes, intravascular hemolysis, schistocyte, also called helmet cells, megaloblastic anemia, hypersegmented neutrophil, CL smart cell, splenic lymphoma with villus lymphocyte with polar villi, follicular lymphoma, you'll see lymphocyte with cleaved nuclei, ALL, you'll see lymphocytes with prominent nuclei. So all these things will really get into your head when you keep on revising them. Teardrop poikilocytes, then the smart cell, then schistocytes broken down. Okay, so stains and reagents used in hematology. So TRAP, like tartrate resistant acid phosphatase, always positive in hairs and leukemia. Sudan black B stain and myeloperoxidase AML. myeloblastic terminal TDT, ALL, and LAP is increase in polycythemia rubra and myelofibrosis, decrease in CML. A very common thing that comes, and also leukocyte reaction. High ALP in LAP in leukocyte reaction. Okay, drugs that can cause pancytopenia are cytotoxics, antiparasitic trimethoprim, chloramphenicol, anti-rheumatoid, penicillamine, all these all the carbas, carbamazepine, carbimazole, sulfonylurea like torpitamide, and all these sulfur drugs as well. Aclamiprovide. No, it's just sulfonylurea for now. Okay, neutropenia, not pancytopenia. Neutropenia is where neutrophils are low. So, on routine full blood count is one of the most common inquiries received by hematologists from primary physicians and hospital doctors. Neutropenia is defined as an absolute peripheral blood neutrophil count of less than 2. So, this is a racial variation. Blood and Middle Eastern people may have neutrophil count more than 1.5 normally. But usually, when you see patients, oncological patients like post chemotherapy patients, they may have these presentations. So what is acquired inherited? Acquired will be infection like viral influenza, HIV, hepatitis, bacterial sepsis. Drugs will be convulsants like phenytoin or carbimazole or chlorpromazine, cotrimoxazole, ACE inhibitor, and immune-mediated SLE failure syndrome, bone marrow failure, like leukemia, lymphoma, hematologic deficiency, splenomegaly, any cause. Inherited can be Cosman syndrome, Shediak, Higashi, Schwamm-Diamond syndrome, cyclical neutropenia. Okay, what do you see? Blood film, hepatinics, iron TMS, all these autoimmune profile blood, um, profile bone marrow aspirate, trephine are indicated if there are severe prolonged neutropenia or features showing suggestive of marrow failure. Okay. Leukocyte reaction describes the presence of immature cells such as myeloblasts, promyelocytes, nucleated red cell in peripheral blood. This may be due to infiltration of the bone marrow, causing the immature cells to be pushed out or sudden demand for new cells. So this infiltration of bone marrow with something which is causing the immature cells to go out of the bone marrow, or sudden demand for new cells. A relatively common clinical problem is differentiating CML and leukocyte reaction. So this may like give identical problems. So this is a way to uh, differentiate between the two. Check the lab score. High lab score is for leukocyte reaction, low lab score for CML. Toxic granulation or dull bodies in the white cells, that's also important. And left sheet of the neutrophils. Increased neutrophils are less than 3 segments of the nucleus. So that's for leukocyte reaction. So what can be the causes of these leukocyte reaction? Can be severe infection or severe hemolysis or massive hemorrhage or metastatic cancer with bone marrow infiltration. So you see the whole bodies here in the neutrophils. Okay, causes of eosinophilia may be divided into pulmonary, infective, and other causes. So 3 types of causes are there. So pulmonary cause can be asthma, allergic, bronchopulmonary aspergillosis, Sturge syndrome, Loeffler syndrome, tropical pulmonary eosinophilia, pneumonia, hypereosinophilic syndrome. All these things can cause eosinophilia. And infective causes can be schistosomiasis, nematodes, Toxocara ascaris, strongyloids, and echinococcus. Other causes can be sulfasalazine, nitrofurantoin, psoriasis, eosinophilic leukemia, all these. Okay. Drugs that feature eosinophilia are diseases that feature eosinophilia. All of them are already mentioned here. Hypereosinophilic syndrome, parasitic infection, allergic disorder, some drug reaction, cholesterol embolization, some form of chronic myeloid leukemia, Hodgkin's lymphoma, Addison's disease. All these eosinophilia, hematologic syndrome. Okay. Okay, useful mnemonic for remembering causes of eosinophilia is NAACCP. So what's that? Neoplasia, Addison's disease, cause eosinophilia, allergen or asthma, collagen vascular disease, cholesterol emboli, parasites. Very good way to remember. Okay, Hypereosinophilic syndrome, another disease, a rare unknown cause disease occurring most commonly in males in 30 to 40 years age group with persistent and markedly raised peripheral blood eosinophil count. So lung involvement may occur, cardiovascular involvement with fibrosis and restricted cardiomyopathy, which may lead to mural thrombus formation, considerable morbidity and mortality. Angioedema or urticaria can be there. Treatment is with high-dose corticosteroids, prednisolone 15 mg, which leads to response in around 50% of the case. Steroid-sparing agents such as glyphosate or azathioprine may also be of some value. Okay, hemochromatosis, as we know, it's like iron accumulation. So hemochromatosis is an autosomal recessive disorder of the iron abnormal absorption and metabolism, resulting in iron accumulation. So some sort of disorder of iron absorption and metabolism. It's caused by inheritance of the mutations HAV gene on both copies of chromosome 6. There are rare cases of families with classic features of genetic hemochromatosis, but no mutation in HAV gene. So presenting features, what can be there? Usually presents in men more than 40 years old. So something to watch out for. Early symptoms include fatigue, erectile dysfunction, and arthralgia of one of the hands. Bone skin pigmentation, very important. DM, liver stigmata of CLD like hepatomegaly, cirrhosis, hepatocellular deposition, cardiac failure, hypogonadism, secondary to cirrhosis and pituitary dysfunction. So hypogonadotrophic hypogonadism, arthritis special of the hand, all these things. Joint X-rays clinically show chondrocalcinosis. Remember that as well. Common question is about which features are reversible with treatment. So how do you reverse the problems? Can you reverse the problem with treatment in some of them? Like these states like cardiomyopathy, skin pigmentation, deranged LFT can be reversed with treatment. Irreversible is like liver cirrhosis, diabetes mellitus, hypochondroplasia, hypogonadism, arthropathy. All these are irreversible. So selected points from British Society for Hematology 2007 guidelines. Patients of North European ancestry with clinical features suggestive of genetic hemochromatosis should have the following: full blood count, LFT, serum creatinine, serum ferritin, and transfer TSAT. Molecular testing for HIV gene GH should allow if SF and induced TSAT more than 50% or more than 40%. So when these two are raised, that's when you do the HIV genetical testing. Unselected population screening for HIV gene mutation is not recommended, and family screening should include parents, siblings, and children over the age of consent. Extended family screening is not recommended. Screening to include all these things should be offered to family members, and investigation of confirmed C28-2Y homozygotes should include all these. Therefore, thereafter, further investigation may be required as follows. So, S serum ferritin less than 1000, normal LFT, and clinical examination require no further investigation. But if SF more than 1000 or abnormal LFT is referred to hepatology for fibrosis, assessment to exclude the presence of cirrhosis. A minimum would be elastography. For patients with combined cirrhosis, monitor AFP and hepatic ultrasound every 6 months. And for liver biopsy, pearl stain, liver biopsy is no longer looking for diagnosis of HIV, but may be required to assess the severity of fibrosis in genetic hematochromatosis patient with SF more than 1000 and increased transaminase. Transient elastography could be used to select which patient from this group will require liver biopsy. Screening for hemochromatosis, general population for full blood count, TFT, LFT, SF, TSAT. So if there is increased serum ferritin and TSAT, it's genetic HIV. Family members, you can do this test. Hemochromatosis is the most prevalent genetic condition in Caucasian population with a carrier rate of 1 in 10 and is present in about 1 in 200 to 400 people. Cystic fibrosis is a carrier rate of 1 in 25 and is present in 1 in 2,500 births. Cystic fibrosis is often quoted as being the most common lethal inherited condition in Caucasians. Okay. Management and monitoring. All fit patients with biochemical iron loading should undergo weekly venesection. Weekly. until creatine is 20 to 30 and T cell is less than 50%. That's the target. During this phase of venesection, the full blood count should be monitored weekly and all this monthly. Homozygotes with normal iron indices and compound heterozygotes with minimum elevation of iron indices may be suitable for blood donation and annual monitoring of all these. During maintenance, venesection as required, preferably at a blood donation center to maintain normal FBC. So, and creatinine of less than 50 and T cell less than 50%. HIV generate genetic hemochromatosis with cirrhosis manages above but not suitable for blood donation. Monitor AFP and hepatic ultrasonography every 6 months, as said before. Okay, next going to amyloidosis and another important topic here. So it's a group of disorders characterized by extracellular deposition of insoluble protein, amyloid protein. So this deposition of protein everywhere in the body, which are abnormally deposited in tissues. Symptoms vary widely depending upon the site of amyloid deposition. So depending on the site, the symptoms will show up. Amyloidosis may be inherited or acquired. So acquired form is associated with long-standing chronic diseases. Acquired forms associated with long-standing chronic disease like DM and rheumatoid arthritis. So diagnosis can be biopsy of the abdominal wall, kidney, liver, rectum, salivary gland can be examined for evidence of characteristic amyloid deposits. The pathognomonic histological features is apple green birefringence of amyloid deposit when stained with Congo red dye and viewed under polarized light. So you put Congo red dye and view under polarized light. What you see is apple green apple birefringence of amyloid deposits. So immunohistochemical staining can be. What is this again? This is again view under polarized light, right? So immunohistochemical staining can identify the type of amyloid fibril present. Quantitative scintigraphy with radial levels serum amyloid P is a valuable tool in determining the overall load and distribution of the amyloid deposits. The nature of the amyloid protein type can be determined by various ways. Okay, protein electrophoresis or light chain determination, binding of particular antibodies to the amyloid found in the tissue, extraction of the protein and identification of its individual amino acids. So what are the types of amyloidosis? Amyloid proteins. It's also very important.